All right, everybody. Let's finish. Oh my goodness, the screen got all messed up. I got thrown out again. All right. Why does it look like this? All right. Everybody okay? All right. So let's talk a little bit about what this guy had. Uh, this patient had, as some of you guessed already, idiopathic pulmonary fibrosis. So this is a type of interstitial lung disease where you get chronic inflammation of unknown etiology. So we don't know why this happens. It's likely that there's some kind of environmental factor that interacts with the patient, predisposed individuals, to cause this chronic inflammation in the lung. It involves only the lung. As far as we know, there's no extrapulmonary manifestations, of the disease. You could get right-sided heart failure if the disease is severe enough, right? No, Sadaf says, why idiopathic pulmonary fibrosis? Because the biopsy showed it. Nobody knew it before, right? There wasn't something special. I mean, he didn't have any occupational exposures or anything like that. But this is the importance of, what did I say? You need the biopsy. So we confirmed it with the biopsy. Nobody's smart enough to say, okay, this is IPF and that's it, right? So I needed the biopsy. So you're right. It wasn't anybody smart, but people guess this for the reason that there's no exposure. So you rule out kind of like occupational lung diseases, doesn't look like sarcoid, so people start to think of IPF. But it's the biopsy that confirmed it. So as I mentioned before, right, it involves the lungs. There are no extrapulmonary manifestations. It usually occurs in the fifth decade of life, maybe a little bit older. The presentation is typical interstitial lung disease. Remember, dyspnea on exertion. The pulmonary function tests show a restrictive lung pattern, intrapulmonary, right? This is intrapulmonary. I for intrapulmonary restrictive disease. The way we confirm that this patient had this disease is we did a bronchoscopy, right? That showed inflammation, but it showed non-specific inflammation. What does that mean? Well, it didn't show anything specific for something else. So for example, when I got the bronchoscopy back on this guy, they told me no granulomas, no evidence of silica fiber, no evidence of asbestos fiber. What are they getting at? Why they tell me no granulomas, no this, no that? They're telling me it doesn't look like sarcoidosis. It doesn't look like occupational lung disease. Okay? Everybody understand that? Right. So you're ruling out with the biopsy other diseases, and you got non-specific inflammation. There's nothing pathognomonic for this disease other than using the biopsy to rule out other etiology. Okay? Everybody okay with that? All right, so now the treatment, right? They don't ask you guys about treatment because they don't know how to treat these patients. Approximately about 20% respond to corticosteroids. All right, so some people try corticosteroids. Some experts say, corticosteroids likely don't work. Others are willing to try it. All right, but they may ask a question here, and how do I monitor objectively if the pulmonary function is getting better in this guy when I start him on steroids? How do I know? I keep him on for 2 years or what? How do I monitor disease? All right? PFTs, right? That's an objective way. So, I do PFTs before and after. See if he gets better. Okay? Everybody okay with that? A lot of these patients eventually go for heart and sometimes lung transplant. They usually go for lung, and sometimes, if they're young, additional cardiac transplant because they have cor pulmonalis. Okay? All right, so watch this. They may ask a question about it. All right, so look at here. This is what I was talking about before. You've made the diagnosis of idiopathic pulmonary fibrosis based on the bronchoscopy results. After discussion with the patient and the family, you decide to start prednisone, 60 milligrams per day. You make an appointment to see him in 3 months. What is the best test, right? Follow-up test for response to treatment. Okay? We did do PFTs when this guy presented. We did. Remember I said intrapulmonary restricted disease, right? So you repeat them in 3 months when he comes back, and you got him on corticosteroids. All right, because if you ask this guy, you're doing better, right? When you ask people on corticosteroids, you're doing better, they usually feel better, right? Now, are they objectively doing better? That's a different story. Okay, everybody okay with that? All right, so you guys understand this well. All right, so let's talk a little bit about sarcoidosis. So we see a lot of sarcoidosis in this country, so you guys got to get, accustomed to managing patients with sarcoid. The 27-year-old woman comes with painful erythematous papules. She also has joint swelling. She has symmetrical polyarthropathy. That's the joint swelling. And she's got 3-centimeter papules over the anterior leg area. Okay? Everybody okay with that? What are the erythematous papules? So that's the most commonly answered wrong question. So people think they're granulomas. They are not. What are the papules? That's what I said. What is this called? They're called erythema nodosum. Erythema nodosum is a hypersensitivity reaction. So it's important because most people think it's granulomas, non-caseating granulomas, because that's what sarcoid is about. But this is a hypersensitivity reaction. Now, you guys know other scenarios where you see E. nodosum? Leprosy. Okay. Lupus. Good. Inflammatory bowel disease. Okay. I don't know about herpes. Right? Erythema nodosum. Maybe drugs. Right? So we see it with tuberculosis, with other mycobacterium, right? Sometimes with different types of infections like staph and fungal infections, right? But sarcoid, definitely you have to think about it. Okay? So what's the answer to this question here? What does the chest x-ray show? All right, see, so they don't ask you what she's got. That's a good question. Okay, bilateral hilar adenopathy. What's the most common organ involved in sarcoidosis? Let's see if you guys know that. All right, Miles. The lung. The lung. All right, what's the most common pattern in the lung? Don't worry about it, Alejandro. Don't worry. Don't worry about it. You got to get it wrong now. Don't get it wrong later. Hold on. What is the most common anatomic pattern of involvement of sarcoid in the lung? I know it's granuloma and stuff, but that's not what I'm looking. All right, Kavita's got the right answer. So I'm looking for bilateral hilar adenopathy. Okay, so what did I say is the most common organ involved? The lung. What's the most common presentation of sarcoid in the lung? Bilateral hilar adenopathy. Okay, bilateral hilar adenopathy. It's bilateral and equal, so it doesn't look like tuberculosis that much because tuberculosis is on one side usually. Okay? Anybody know what most commonly happens to the lung disease in sarcoidosis? 80% of the time, it stays the same or goes away on its own. Okay, now can you guys remember those three things? Lung, hilar adenopathy goes away or resolves. All right, keep that in mind. If you guys know those three things, you know a lot about sarcoid. Most people forget. All right, so sarcoidosis, as some of you mentioned, it's a chronic granulomatous disease. The importance is that they are non-caseating granulomas, right? Compared to what? Compared to caseating, which is what? What's that? When I hear caseating granulomas, I start to see if everybody's coughing next to me. Tuberculosis. Now, can you guys tell me other causes of non-caseating granulomas, like sarcoid? Fungi, Crohn's disease, very good. So there's a lot of other ones, right? All right, so this is not pathognomonic for sarcoid. Very good. Okay, we said lung is most commonly involved. And what's the most common way it presents? It's hilar adenopathy. All right, so this hilar adenopathy, many times it's asymptomatic. Not always. As an example, this patient was symptomatic, but hilar adenopathy is commonly asymptomatic. All right, so now other areas involved. Well, remember this case. Skin, right? Eye. Oh, the eye is a big deal. All right, so what's the eye environment? All right, Jonas said uveitis, conjunctivitis. So this is a big deal. Anybody know why it's important to look always in sarcoid patients for symptoms in the eye? Why is it very important to make sure you don't miss them? Because right, so they could get, in severe cases, they could even get blindness, right, in severe cases. Okay, it could present with joint pain, just like this patient, symmetrical arthropathy. It could have CNS disease, right? It could touch the peripheral nerves. It could cause GI symptoms, so the esophagus and other parts of the GI, even the kidney. All right, so they want you to remember lung, eye, and skin. And CNS is rare. All the other ones are rare. You could even have heart disease, right? But please, skin, especially erythema nodosum, eye, because it's important that you treat it, lung, because it's the most common organ involved. Everybody clear on that? It is the most common organ involved. Okay? All right, very good. All right. In the laboratory, all right, so this is the other one you guys got to know. Hypercalcemia. All right, we talked about this. All right, come on, go back to endocrine now. Why do these patients have hypercalcemia? All right, Fausto says the macrophages activate your vitamin D, and you get a hypervitaminosis D, and you absorb more calcium. All right, so they go out in the sun and they get more calcium, and that's how they get hypercalcemia. Okay? All right, very good. Hypercalcemia is a very important sign because, as some of you mentioned, it gets treated with corticosteroids, right? So all the other hypercalcemias, we're giving fluids, we do this, but this one, you got to give fluids and stuff like that, but you got to give corticosteroids. Very important. Okay? The prognosis. Well, let's look at the lung because the lung is the most commonly involved. All right? 80% lung lesions improve without treatment, right? So there's some people, pulmonologists, experts say, that's why I don't treat sarcoidosis right away, because 80% improve or they don't worsen at least, right, in 80% of the cases. Okay? All right. How do we diagnose? You biopsy the involved tissue. If there's any questions, sometimes sarcoidosis is very clear cut. But if there's any questions, you biopsy the involved organs, right? And you find non-caseating granulomas. And the biopsy rules other stuff out. Other stuff that you want to make sure they don't have, like, I don't know, tuberculosis, like lymphoma, and stuff like that. Infections, of course. Okay, be careful. some of the old literature, and I know even some of the current literature in some other parts of the world, they tell people to diagnose sarcoid by using elevated angiotensin converting enzyme levels. Okay? Please, please do not use this. Okay? They are useless in the diagnosis of sarcoid. In the diagnosis of sarcoid, they are useless. Mandeep said in the follow-up they may have some role, and the answer is yes, they may, but not in the diagnosis. How do you diagnose this disease? How do you diagnose this disease? What did we just say? How do you diagnose it? Biopsy. There you go. Okay? All right. What's the treatment? The treatment is corticosteroids, but I told you, not everybody believes you should treat pulmonary sarcoid right away. So clear-cut treatment involves eye, all right, central nervous system you know about. All right. So, and hypercalcemia. All right. Those two need treatment. The lung is questionable. Okay. All right. Well, you have to do the chest x-ray before, right? Because you got to know where you're going to biopsy, where the likely lesions are. Right? So we do a chest x-ray like we did in this guy, and we usually biopsy the lungs, right? Because 80% of the time, that's where it involves. If you got other organs involved, then you may go after other organs. But typically, we do the chest x-ray. Okay? Everybody okay with that? Listen, there's going to be one question about sarcoidosis. At least one question. Everybody okay with that? Okay. One more thing I want to tell you guys. This is the case, all right? This case, they may ask you something very similar on the USMLE. A 27-year-old man is found to have bilateral hilar adenopathy on a routine chest x-ray before starting his job. So he has no symptoms at all. Fausto says, is he African American? So he may be, all right? Because this is more common, right? But it's common, you see it everywhere. He has no symptoms. Look at this. No symptoms. Feels well overall. The physical exam and lab tests are unremarkable. Okay? What do? We watch and wait. Okay? We watch and wait. Repeat imaging in about 3 to 4 months. Okay? All right, so you don't have to do a biopsy here. Okay? Biopsy is for symptomatic patients. This patient is asymptomatic. So if you find bilateral hilar adenopathy in patients, what do? Check for symptoms. If the symptoms are positive, you got to biopsy and confirm. If there's no symptoms, watch and wait. Okay? Watch and wait. Bilateral hilar adenopathy. You assume it's sarcoid and watch and wait. Okay? Everybody feel comfortable with that? Okay, very good. All right. All right, so now I want to talk, well, it's going to, so Aranima says, what if it's still present after 3 months? It is going to be present after 3 months. Why are you doing the x-ray? What are you looking for? You want to make sure what doesn't happen in 3-4 months. It's going to be there. This guy's asymptomatic. Remember, if they have symptoms, you got a biopsy. I'm talking about an asymptomatic patient here. So once you do, let's talk about that. When you repeat the imaging in a few months, why are you doing it? You want to make sure what? What do you want to make sure it doesn't happen in 3 months? Right, so it's either hopefully smaller or there's no progression, it's not getting worse. Now, if you look at it and it's gotten bigger, well, now you're in trouble. You better go in and biopsy it and, make sure it's nothing else. If the guy has symptoms, you got to go in and biopsy it at some point. Okay? Everybody clear on that? Okay, very good. All right, so we want to finish this chapter, right, talking about occupational lung diseases. So they love to ask you guys about occupational lung diseases because it is very common in this country and it's underdiagnosed. Okay, the occupational lung disease that we have to know is asbestosis and silicosis. Those are the two that they really ask about. They ask about both of them. Co-workers pneumoconiosis, I'm going to tell you a few words about, but it's less likely to be important. But the asbestosis silicosis, we have to know it. Other occupational lung diseases, we don't have to know. What happens in all occupational lung disease, the pneumoconiosis, right? The occupational lung diseases. You inhale the fibers, right? See, you're not wearing the protective mask, and honestly, 30, 40, 50 years ago, people didn't even care about it. They thought, wearing a mask, was for sissies or something like that, right? So you would inhale the fiber, you would do all this work and stuff like that. You would inhale the fiber, it would go down into the alveoli, right? It would activate the macrophages. It would cause an inflammatory process, right? And what do you get after chronic inflammation in the lung? Fibrosis, right? And then you get the restrictive pattern that you all just mentioned, intrapulmonary restriction. So the fiber that you inhale causes the chronic inflammation, right? And 20, 30 years later, the guy comes in with interstitial lung disease. The most important clue, the most important and the most important test to do is to get a positive exposure history. So the history here, right? The history in pneumoconiosis is the most important test. I really mean this. You gotta get the right history. Okay? As I mentioned before, it typically occurs 20 to 30 years later. Right? So, and it has the classic interstitial lung disease presentation. So what do I mean by classic interstitial lung disease presentation? Tell me some classic, findings. All right, dyspnea and exertion, very good. Other things, restrictive lung disease with decreased LCO, very good. How about on the chest X-ray? Interstitial lung disease, right? Fibrosis, right? Ground glass, and so forth. All right, there you go. All right, here the biopsy is mandatory. All right, before you, in all ILD cases, you have to do it, but here it's even more important because litigation issues come up here. Not with the physician so much, but with the company this guy worked for or this woman worked for. So very, very important to confirm from the biopsy what this patient has. Okay? All right, so let's talk about the specific ones. The asbestosis is caused by the asbestos fiber, right? So it looks like a dumbbell, kind of like, something like this. This is what these patients breathe. It goes down into the lungs, right? And it causes chronic inflammation and eventually fibrosis and scarring of the lung. The association, remember, we've got to get a history here, right? Is with certain occupations. We see it in shipyard workers, right? People that have been shipyard workers, they used to use in the ships asbestos as insulation, right? So, well, now we don't see it anymore in shipyard workers. But if you guys live around a big shipyard like in Baltimore and Annapolis here, right? This is why they have a lot of asbestosis here, because people 40, 50 years ago have worked in those areas, right? And then insulation, We don't see that in insulation anymore. People that worked in insulation 40, 50 years ago get it. People that used to work with brakes, car brakes, they used to use asbestos in the car brake linings, again, as insulation, right? So this is important to try to get. Now, as time goes by, yeah, you guys are right. We're not going to be seeing it in these occupations anymore because they've taken asbestos away. People have done a good job in the last 30 years or so to reduce risk. Asbestosis typically presents with lower lung infiltrates. So when you look at the X-ray, right? So the interstitial densities involve the lower lung, right? And then the other thing they tell you about is sometimes you have what are called pleural plaques. See in the pleura here, right? Pleural plaques. So you have these calcifications in the pleura and sometimes over the diaphragm, right? Very, very important to look for them. The risk for cancer is very high in patients with asbestos exposure. So where's the risk? It's for bronchogenic cancer. All right, this is number one. All right, people forget this. They think, oh, mesothelioma, mesothelioma. No, it's lung cancer, number one. What's number one cancer? What's the number one cancer in asbestos? Lung cancer, bronchogenic cancer, all of them. All right, now, does anybody know what happens when people smoke here? Well, it's a formula for disaster. Right. Eddie says 75 times. That's exactly right. 70 to 75 times the risk of normal people to get lung cancer. I mean, it's painful. So what's the best thing you could do to this guy? If they smoke, what do you tell him to do? Stop today. Stop today. Right. So 75 times the normal population. Right, so that's the best thing you could do. You can't reverse this, right? You cannot reverse this, but the best thing you could do for this person is to make him stop smoking any way he or she can. Okay, now mesothelioma, some of you mentioned, is also higher risk, right? So asbestos patients not only get bronchogenic cancer, but they get mesothelioma. All right, mesothelioma is less likely, right? But it's the risk is higher than the normal population. But the one you got to worry about is lung cancer. Okay? Now, anybody know what's mesothelioma? What's mesothelioma? It's not lung cancer. There you go. Patients say it's pleural cancer. Very good. It's a type of pleural cancer. Okay? Everybody okay with that? So watch asbestosis. They might ask a question. No, they're going to ask a question about asbestosis or silicosis, or maybe both. All right, so you see this X-ray? So this guy was a shipyard worker, right, in the Baltimore area. All right, so you see the calcification of the pleura, right? You see here, right, right here, right, the calcified diaphragms, right? And look, all this stuff here, you see all that? That's all calcifications here, right? All calcifications, mostly in the lower lobe, but this guy had disease in the upper lobes. He was bad news, okay? All right, watch this. When we biopsied this guy, right? You guys see that? No, this guy didn't have cancer. These areas here, right, are pleural plaques. They didn't have cancer yet, okay? All right, so these are asbestos bodies, right? There you go. Wonderful. Right, ferruginous body. Very good. No, Eddie, that's a great question. You know, people say like, look, I don't want to touch this guy. This guy's like radioactive. No, this guy, you gotta see the fibers have to be in the air, right? And you got to breathe them in. The asbestos fibers in patients, they're in the lung. They're not going to go anywhere, right? Everybody understand that? You can't get them out of there. That's the problem. Okay? Everybody okay with that? All right, so they're trapped, unfortunately. All right. So watch this. Asbestos is a great question for you guys to see how you guys are thinking. All right, so the other one we said is silicosis. So silica dust, right? They breathe in silica dust. So the association now, the occupational association, is sandblasting, mining, glass and pottery. So you hear about quartz workers. That's why it's important when you work with quartz or you sandblast and stuff like that. These guys have to wear masks, right? So now silicosis, unlike asbestosis, involves the upper lung fields. So it kind of looks like this, right? Sometimes the lymph nodes here are calcified, right? So you may get these things called eggshell calcification, but the bottom line is mostly upper lung infiltrates. All right, so these guys are not at risk for developing lung cancer, right? But Jonas correctly said they are at risk. The big risk here, the big association is tuberculosis, right? So they asked the question, in somebody exposed to silicosis, so this guy's got a silicosis lung, right? And comes to your clinic for follow-up, what do you do? What are you checking this guy? So now they check to see whether you understand like how to test for latent tuberculosis. Right. So you do a chest x-ray, but you place a PPD. That was the right answer. Right? So you got to catch this guy early positivity and treat them. Okay. 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 All right. So let's finish this hour, right? Talking about so uh, talking about pulmonary embolism. Let me tell you guys just a few words about co-workers pneumoconiosis. So co-workers pneumoconiosis has to do uh, with the uh, uh, with the coal, the size of the coal, the harshness of the coal, right? It minors usually get exposed to it. All right. Does anybody know what happens to these patients? It's not associated with TB. It usually is not associated with cancer, but what is it associated with? Co-workers pneumoconiosis. Right. So you get this thing called Kaplan syndrome. Right. So Kaplan syndrome is look at here. So this guy's got fibrosis, right, in the lung, like this, from co-workers pneumoconiosis, like this, and now you get these nodules in the lung, right? We don't see this a lot anymore, right? But you get these nodules from rheumatoid arthritis. So it's Kaplan with a C, right? So it's rheumatoid arthritis and co-workers pneumoconiosis. That's Kaplan syndrome. Okay? That's what we got to remember for co-workers pneumoconiosis. These patients, for some reason, when uh, they inhale the coal dust, this causes an inflammation not only in the lung, but a peripheral inflammation. So their rheumatoid factor goes up, right? Their rheumatoid factor, the immune globulins go up, right? Anti-nuclear antibodies are positive, right? Stuff like that. Okay? So immune mediated abnormalities. Okay? Everybody okay with that? Right? So that's what we got to remember about co-workers pneumoconiosis. Okay? Good. So let's finish talking this hour about pulmonary thromboembolism. Yeah, everybody gets a biopsy. Remember that? Especially with occupational lung disease, right? Everybody. Okay? All right, very good. ANA is anti-nuclear antibodies. This is like lupus, right? And stuff like that. So remember I said it causes an immunologic response. Okay? All right, very good. So I want to finish this hour talking about thromboembolic disease, thromboembolism. All right, so look at this. A 32-year-old woman comes to the emergency department with shortness of breath and pleuritic chest pain. She takes oral contraceptives, but otherwise has no significant past medical history. All right? So her respiratory rate is 26, right? Her pulse is 107. Kavita says oral contraceptives put this woman at risk for hypercoagulable state. And you're right? Because when they saw her in the emergency room, they thought, she was anxious. She was anxious, I don't know, because she was shopping too much, something like that, right? Physicians always, this guy's neurotic or this woman's neurotic, right? So, but there's a couple of things here that should have, that's right, that should have said to you, well, something else is going on. Her lung and her heart exam are totally unremarkable. All right, so you do the ABG, right? And what do you notice? What do you notice? She's got alkalosis. Okay, she's got alkalosis. Her CO2 is decreased, 25. Her oxygen is 25. All right, let's see if you guys were paying attention yesterday. What is her AA gradient? All right, Faisal said it's increased. But it'd be nice to tell me though, right? So remember, 150, right, minus, right, what's the CO2 times 0.125, right? So that's what? Say that's about 30, okay? About 30. And then minus from all this, the oxygen, right? Right? Everybody okay with that? Or you could do it like Mercy did, 25 divided by 0.8. I said 30. All right? All right, what's her A gradient? 50, or even more. I mean, it's at least 50. Okay? At least 50. Everybody okay with that? Around. Now, you guys probably, if you do the exact calculations, you probably get it probably even a little bit more. Okay? Wow. Eddie said 48.75. Okay. All right, good enough. All right, so what's a normal A gradient? Yeah, definitely way more than normal. 10, right? Maybe 15 the most. Mm-hmm. Definitely abnormal. So look at this now. So this is an important finding. The chest x-ray is normal. Why is that an important finding? Because if you found something on that chest x-ray, you say, okay, she's got a pneumonia, or she's got atelectasis, right? Or she's got pneumothorax, right, causing this. But if you don't find anything on the exam and the chest x-ray, what's causing the hypoxemia and the A gradient? It's not in the lung parenchyma. Where is it? Right? In the lung vessels. There you go. See? So it's not, doesn't have to be in the lung parenchyma. It could be in the lung vasculature. There you go. Okay? In the circulation. All right. So let's talk about this very interesting disease. There you go. So Kavita is already doing spiral CAT scans, right? So now the spiral CAT scan is called what? What's the, because they're all spiral now. What is that called now? What's the spiral CAT scan called now? What's the right terminology? Good. Kayer said CTPA. That is exactly right. a CTPA, CT pulmonary angiogram. That's what it is. You do a CAT scan that shows the pulmonary vessels, right? Thin cuts, right? Because they're all spiral now. Since about 6, 7 years ago, they're all spiral. All the new CAT scanners are spiral, right? Okay, so PE arises from where? The deep veins, the proximal deep veins. 80–90% of the time, they come from the lower limb. Why is it important to know that history? Because a DVT and a PE is the same disease. We look at it as the same disease and we treat it the same way. Everybody understand that? Treat it the same. All right, so if I told you this guy's got a popliteal DVT, you're going to treat it just like he had a PE. There you go. Everybody understand that? They're one and the same disease. All right. They arise from what? Not all DVTs, proximal DVTs, right? Proximal DVTs. What's proximal DVT? Above the knee. Above the knee. But did it start above the knee? There you go. Then mine says it started below the knee. So it starts below the knee. It's not dangerous, but when it propagates above the knee, now it becomes dangerous. See, distal DVT, very small risk for PE. The problem is when it propagates, right, and it goes above the knee, now you're in trouble. These are the ones that break off and go into the lung. Everybody understand that? So where did the DVT start? Distal. Is a distal DVT dangerous? No. What has to happen? They have to propagate. 30% only propagate. When they propagate above the knee, what happens? Now you're in trouble. Now that becomes a pulmonary embolism. Okay? Everybody okay with that? All right, now you guys clinically are going to see some other causes of DVTs just because of changing landscape of medicine. We see upper extremity, subclavian, internal jugular vein thrombosis. These used to be rare, very rare 30 years ago, 20 years ago. Now we see a lot of it. Why? Because we got patients with a lot of catheters, right? So I put a catheter in a guy, sent him home so he could get treatment at home. These cause upper extremity DVTs. So watch when patients start complaining of, arm swelling. Always, yeah, PICC line, right? Always think about, thrombosis there, especially with ports, with PICC lines and all that stuff. Okay? The other exception to proximal DVTs causing PE is pregnancy, right? Pregnancy, pelvic veins, right? So in pregnant patients, you could have a DVT up higher because of the pressure, right? That's the theory, all right? So think about all that stuff. 80–90% of the time, though, where does it start? Where does it start? Where does it start? In the distal veins, and it propagates to the proximal veins. There you go. Okay? All right. So for the exam, pulmonary embolism and DVT are one and the same disease. Everybody understand that? Proximal vein thrombosis always has to be treated just like pulmonary embolism. Okay? Distal DVTs, only when they propagate do you get in trouble. All right? So watch this now. Superficial vein thrombosis. Okay? You don't have to worry in the lower extremities. All right? So varicosities, right? You don't have to worry about that. Everybody okay with that? That statement is correct. All right, so now they gave a case of a superficial femoral vein thrombosis. Superficial femoral vein thrombosis. Can you guys remember that? Superficial femoral vein thrombosis. What does that mean? There you go. Denise, you got it. So they're trying to trick you, right? They're trying to trick you, right? It's because it's part of the deep vein circulation. Why do they call it superficial? Because we always, physicians always got to say something to get everybody mixed up, right? It's a true deep vein. It's superficial to the other deep veins, but it's not a superficial, vein that we don't have to worry about. Okay? Everybody understand? A superficial femoral vein has to be treated just like a proximal DVT. Everybody can remember that? You guys going to remember that if they give you that, right? You're going to treat it and say, uh-oh, that's PE. That's like PE, right? Same thing. Okay? All right. And we mentioned about pregnant patients, IV catheters, looking uncommon places and so forth. All right. Now, what, kind of puts a light bulb in our brain, lights up? Well, it's high-risk patients. So some of you just right away, when I said that case, you guys said, boom, she's high risk, right? You should think about, working her up for PE because she's high risk. Some of you said she's taking oral contraceptives, right? And, you should think about maybe pulmonary embolism in this case. So this high risk group, triggers the thought of pulmonary thromboembolic disease. So who is this high risk group? Well, there's different categories here. So for example, people that have had recent surgery, especially orthopedic surgery, right? There's well score. Now you could, do the well scores, but follow me here in terms of high risk patients, right? So orthopedic surgery, like what do I mean? Which orthopedic surgery? Am I talking about, hand surgery? Yeah, hip, right? Hip, especially hip, maybe knee too, right? So, the orthopods were the first people to pick that up. They said, but my patient did so well after surgery. Well, the patient died 7 days later from saddle embolus, right? So the orthopods, they like good outcomes and they want to sustain good outcomes. So they figured this out. And something's up here. These guys are, thrombophilic. So they would put them on anticoagulants. The second category is cancer. This is an important category. People with cancer now are living longer. So we see more and more of their thromboembolic risk. All right, so here's another thing you guys got to remember. You got to remember a couple of studies that were done about 15 years ago. So they looked at people with unprovoked thromboembolism, DVT, and sometimes pulmonary embolism. Unprovoked. What does that mean? They didn't fly, they didn't, get orthopedic surgery, they weren't taking medication, and they treated them, right? They couldn't find out the reason for their thromboembolism. They followed them over time. They followed them over the next 2 years. Guess what happened? What happened in a good percent of them? Like 25, 30%. They developed cancer. They developed cancer. So we always, when we see thromboembolism, we always do a good exam to make sure we're not missing cancer. We always make sure that this patient has had the age-appropriate screening, right? Very, very important. Follow patients closely with unprovoked thromboembolism because of this risk. Okay? All right. And then there's some other ones. Immobility. All right, here we go. Economy class syndrome, right? Oh, they're squashed. They're going to Australia. They're going to go and, visit the Great Barrier Reef and stuff like that. And they walk off the plane, they get an embolism because they've been 24 hours, right, like a sardine, right? And then that's why they tell you, right, to move around, right? That's why you got to go and do those exercises. That's right, Prit. But now, but even the people in the, economy and the first class and other people get it too. So it's not like they're totally, they totally avoid this. All right, and then there's the acquired thrombophilia, acquired. So you don't have it when you're born, but you get it later, right? So this is medication. This is the lupus anticoagulant. Anybody know another name, right? Another name for the lupus anticoagulant? Antiphospholipid antibody syndrome or anticardiolipin antibody syndrome. Very good, right? They found it in a lupus patient originally, but people get it that don't have systemic lupus. Okay, very good. And people taking oral contraceptives, like our patient gets this, right? Because maybe there's something up with their factor V when they take oral contraceptives. Who knows, right? And how about this? Who knows this story? This is a good one. Nephrotic syndrome. You guys got to know this. All right. Arastip says you lose in the urine, right? What do you lose in the urine in nephrotic syndrome? Protein, right? You lose albumin, right? So they postulate that you lose antithrombin 3 because antithrombin 3 is about the size of albumin. So if you lose a lot of antithrombin 3, you have acquired antithrombin 3 deficiency. I don't know about protein CNS. Now, some people say maybe that's a story too, but definitely antithrombin 3. Okay? Anybody know where they get hypercoagulable? Where do they have thrombus? And this is it's kind of like a interesting story. So they got nephrotic syndrome. Where do they get thrombosis? Renal vein. All right, Puneet. Beautiful. Renal vein thrombosis. You got the disease in the kidney, you lose antithrombin 3, you get thrombosis in the kidney. All right. So you guys got to know this right here. This is the most common cause, the most common cause of inherited thrombophilia. So I just, had a friend who was, a well-known physician in this area, and he started to travel a lot, in the Far East and stuff like that, and he developed repeated thrombosis, and he's got factor V Leiden. So what's this factor V Leiden mutation business? What's this factor V Leiden mutation? Right, so yeah, you go. Denise says you get protein C resistance. You know why? Because here's your protein C, right? So here's kind of like your protein C like this, right? Now let's say it looks like this. So it's not activated. Your factor V attaches here and activates protein C, right? In order to get protein C activated, you got to get it through factor V. If there's a mutation, it doesn't cleave protein C, it doesn't attach to protein C, you don't get activated protein C, so you get protein C resistance, right? And now this causes the thrombophilia. This factor V Leiden is a big deal because people of European descent, right? European descent, there's a big percent of patients that have this, right? Big deal. So they may ask you guys about this, factor V Leiden. Okay? What's the most common thrombophilia? Factor V Leiden. Who typically has it? People European descent. What happens? You get protein C resistance. So your protein C levels are normal, but they don't work. Okay? All right. You guys want to take a break? Let's take a break. Let's take a 10-minute break and we'll come back at 8:12. Right, break. You guys had enough. All right, see you back here in 10 minutes.